Next, we're going to have Andrew Tran giving an update on MIS deformity.
All right, thank you. Here, my disclosure is nothing relevant for the talk today. Really, the big disclosure is I've transitioned my open deformity practice primarily open to circumferential MIS surgery when feasible. And the reason is I really believe in the benefits of this surgery. You know, you're getting your correction with the anterior cages and the lateral cages, and that lets you just do percutaneous posterior surgery. And I think sparing that muscular envelope, sparing the ligaments, very important for these patients in the long-term recovery and following them with deformity. So, you know, now we've had propensity matched analyses that have shown CMIS compared to open surgery has the same clinical outcomes, same radiographic outcomes, and less blood loss, so the safety profile is better. And this has now been extended to 2- and 3-year studies as well, so it's safer. But again, it's not for everyone. This is a patient I have with neuromuscular scoliosis. She's going to have a different surgery, right? It's going to be open. But this notion that there's an ideal CMIS candidate, one with maybe not too big perturbations in the sagittal plane or pelvic incidence, lumbar lordosis mismatch, or even the coronal Cobb angle, maybe needs a little bit of revisiting, especially as we get new technologies and we can perform these surgeries and we do them better. You know, this is Dr. Mumaneni's MISDEF2 algorithm, and one of the key factors that leads someone to say, I'm going to do open surgeries if there's more than 5 levels of fusion, that's that recommendation from the algorithm. And I'd say that might not necessarily be true, and you know, these are the annoying pop-ups that happen when you're thinking about these things. So one of the things that's changed the game for me in my practice is the use of these patient-specific devices, patient-specific cages, patient-specific rods. They're very important, and the reason why that is because that's the key workhorse in MIS scoliosis correction. The inner body work is the initial correction in the anterior column, and you still do get rod rotation and reduction with that rod at the back, and that's the final touch. We don't have the luxury of osteotomies. We don't have the luxuries of compression, distraction, in situ rod bending, so we have to get it right just with the instrumentation. So here's a case. I'll walk you through how I do this with these cages. So this is a 77-year-old lady of mine, scoliosis, severe back pain, and bilateral leg pain. Coronal Cobb of 41 degrees. She is sagittally and coronally malaligned of 10 centimeters off in the sagittal plane, 22 degrees of mismatch, and then she's retroverting even just to get that, and she's off about 3.1 centimeters in the coronal plane. You see that the spine is a bit rigid. We see that there's an autofusion at L2-3 with ankylosis at 5-1 as well. And so you start thinking, is this going to be too stiff for circumferential MIS surgery? Is this something I'll have to do open with Smith-Peterson osteotomies? There is a level with quite severe stenosis as well. So the question is, when you're planning, what are you going to do? Well, of course, as you'd suspect, this is an MIS talk, so I chose a circumferential MIS approach for this patient. How I did this for this particular patient was L4 to S1 ALIF, T12 to L4 lateral with patient-specific cages, and then percutaneous pedicle screw placement from T9 to S1 with bilateral S2 AI screw placement with SI joint fusion. But that's easy to say. We have this spine. How are we actually going to get that straightened out? So the first thing is, when I'm thinking about these in general, where's the inflection point? How many A-lifts am I doing, or how many L-lifts am I doing for the anterior column? Well, generally, with the higher Roos lead types, I am using more A-lifts, but for the lower Roos lead types, I only use a single level L5-S1 A-lift and laterals the rest of the way. Next, I'm actually planning segment by segment with the vendor's apps. What you do is you actually can go segment by segment, plan the lordosis, plan the regional lordosis, and then also plan the anterior and posterior heights, and most importantly, posterior height, because that's where the nerve is, right? And so once you have that, it's a key to think about this main issue. So traditionally, we've had a trade-off, right? If we do a 30-degree hyperlordotic cage, you know that the back maybe is 4 millimeters, and you're worried about that L5 nerve getting crunched. Well, now, as long as it's within FDA tolerances, you can actually still maximize segmental lordosis and still get, let's say 8 millimeters of posterior height or whatever your preference is. So it's no longer that trade-off. The next thing is you do have some interplay. You work with the engineer. So for example, the questions for this case were, what are you going to do with L2-3? Are you going to actually open that space up or just leave it fused and you then have to change your cages appropriately? Same thing at L5-S1. Do you think I can actually pass the osteotome and open that space up, or is it still going to be pretty collapsed and coronally, tilted? So then I say I can open both those spaces up, and then we can visualize how that looks with the bones, right? So part of their AI recognition is the recognition of the bones, and then you can actually change the spine to your segmental lordosis, posterior foraminal height goals, and then you 3D print the cages to that new conformation, and it's also conformed to the end plate topography as well. And so ultimately, you get each of these cages segment by segment. They give you a plan size. You also have a minus size and a plus size in case there's any sort of issue with flexibility. And then ultimately, you're going to the surgery. Now, the key is I then have a patient-specific rod, so actually the patient-specific cage company, I can actually send the exact cage specifications to the rod company, and then they actually have the exact measurements to posterior heights, and that's very important, as in MIS deformity, I'm not cutting this rod after you pass it the first time, it has to be the perfect length. So that's why it's very important that these two interplay. And so you can see here, this is the plan ultimately for that patient-specific rod from T9 to S2AI. I use a 5.5 titanium rod for these cases, 2 of them, and this is ultimately the planned rod. So I take this and I go to execute the operative plan. So in terms of step 1, I do stage D surgery. So this is an EOS scan that I get in between the 2 stages of surgery. You can see that the coronal plane is, modestly corrected already, and there's actually, already the sagittal plane's fully corrected. Next day, you take the patient for the percutaneous approach. What I do is I navigate these percutaneous screws to bring in the arm, and then here's what the percutaneous screws look like ultimately. But the key is, how are you getting from this to your actual plan? And again, it's that rod reduction and rod rotation. So, you pass the rod percutaneously, get it through each of the towers, and then ultimately the key here is that you need to have a system where you could reduce on these towers. And you need to be able to do it across all of the towers and do it sequentially. Because the key is in MIS deformity surgery, we're not looking at the bone screw interface. So you don't want these screws to ply, don't ask too much of one. You want to distribute the forces all the way across, so you can see that we're gradually doing that and correcting this patient. And ultimately, here's a 2D long film right at the end of surgery. You see excellent correction. And then you see in the long term, in terms of their standing scoliosis films, that we hit our target, in both globally sagittally and globally coronally as well. And here's just the sagittal plane and the coronal plane as well. So the key is that I told you, inner body work is the initial correction of MIS scoliosis surgery. And we know with stock cages, this is a study I wrote with the MIS ISSG, that there's a group of patients after circumferential lateral surgery that are still having coronal plane imbalance, about 28%. So clearly, we need to be doing better, and these patient-specific cages have helped me hit my target. So I've told you now that for these long segment surgeries, we're able to hit our radiographic targets. It's not a MIS shortcut surgery. We're doing exactly what we would do in open. But is there an opportunity here now to make our surgeries even smaller with these cages? And I submit to you this case for that. So this is an 80-year-old woman of mine with scoliosis, and her main complaint is her coronal plane imbalance. She says, I can't stand up straight. I keep leaning to the side. And she's very sick. She has this lung transplant, aortic stenosis to post TAVR, CAD, chronic steroid use, CKD. She's not healthy. So when you're thinking and devising about a surgical plan for her curve here, where she's off 5.2 centimeters to the left, she has a true type C curve, albeit 2 configuration, are you going to be able to do something smaller? I mean, part of the issue is the fractional curve has that up-down foraminal stenosis, but again, her main complaint is the postural issues. And it's a bit ankylosed and stiff down there, but the disc spaces do look open. So what are you going to do for this patient? Is this someone we have to do a big open surgery, upper thoracic to pelvis? She has weaker bone. Then we just have to go big, bite the bullet. Is it something we're going to do lower thoracic to pelvis? And what's getting in vogue is when someone's so shifted that you feel like they're stiff, you've got to do that kickstand rod. That's an open surgery. Or is there something you can do that's even smaller? Well, I submit to you that there is. And so what I did for this patient is an L3 to S1 ALIF with patient-specific cages and a percutaneous pedicle screw placement L3 to S1. So again, what you can do is with the application, look at what the correction is intended to be, manipulate the spine how you want it, and then 3D print the cages specifically to that correction. You can see your segment by segment lordotic plans, your posterior height plans, make sure you're hitting your targets there, and ultimately then having a replicable result in both the global fashion, but also at your targeted levels as well for the neural decompression. So these cages, these rods have really helped me in my sagittal and coronal goals in achieving them in surgery. They've also helped me limit the extent of surgery. The cages, because of the way they conform to the end plates, decrease the chances of subsidence. In this large multi-center study, they showed that the average correction is within 1.1 degrees of goal when you use these cages. So that's fantastic in terms of, at least hitting your target. Mike Kelly will tell you which those targets are. So take-home messages here. I think we have to dispel this notion that CMIS is shortcut surgery, that you're doing something small and it's okay that they're malaligned. We'll get them back later if they need to. They're not going to tolerate it. You still can hit your global alignment goals, and that's very important in MIS deformity surgery. I think the patient-specific rod advantages and the cage advantages are very helpful from multiple sources of benefit. Pre-planning, you're now spending time planning. It also it helps you with intraoperative execution, and so that you save cognitive load for other things that matter. And it can also limit the number of levels that need to be treated. And now, overall, your CMIS deformity correction is more reliable. even for more severe deformity and even in limited fusion contexts. So thanks.